Hi, and welcome to our first DiSH a la carte summer mini session for 2021. I'm Whitney Beaton, and I'm the clinical nurse specialist for pediatric diabetes at the American Family Children's Hospital in Madison, Wisconsin. And I'm also a member of the DiSH Planning Committee. Today's session is intended to provide some basic information related to our most commonly used insulins. The objectives for today are to review physiologic insulin secretion patterns, to discuss modern plans for insulin administration in children with diabetes, to review the basics of how long-acting and rapid-acting insulin work, and also to identify variables that can cause variation in insulin action. Insulin is a hormone, a messenger in the body, that's made in the islet cells in the pancreas. Some of the cells within the islet cells make insulin, and those are called beta cells, and some make glucagon. Those are called the alpha cells. Recall that insulin allows the glucose to get into the cell to be used for energy. And glucagon, which is I always think about it as the opposite of insulin, is the hormone that causes the liver to release stores of sugar to raise blood sugar in the event of a low blood sugar, but also to maintain blood sugar within the desired range when you're not eating. Insulin is usually secreted by the pancreas in two ways. There's what we call basal secretion. This is where small amounts of insulin are secreted even when we're not eating. That type of insulin secretion is triggered by a thermostat-like sensor in the islet cells that monitors blood sugar levels and attempts to keep them within that desired range. Then there's mealtime secretion, and this is when a larger amount of insulin is released to help the body turn food into energy. This secretion is triggered by the taste, breakdown, and movement of food within the digestive tract. Modern plans for managing diabetes try to mimic the way a pancreas secretes insulin. For children who give insulin by injection, they typically give two types of insulin. One is a basal insulin. This insulin is usually given one time each day, and then that dose lasts most of the next 24 hours. Then bolus insulin is given with meals and snacks to correct a high blood sugar. This type of insulin usually works in the body for about 4 hours. Children on an insulin pump typically only use one type of insulin, and that's rapid-acting insulin. But it's delivered to meet both basal and bolus needs. For those on a pump, basal insulin drips in by a continuous infusion all day long. And the fact that you get little drips all the time means that we can vary that basal dose up or down to help with fine-tuning insulin delivery to match the body's needs. Children on a pump also command the pump to deliver boluses for meals and snacks and to correct a high blood sugar. And again, each of these doses typically lasts about 4 hours. Multiple daily injection and insulin pump plans typically allow children more flexibility with eating. Because most children with diabetes in our practice count the carbs in the meals that they eat and give insulin to cover those carbs, they typically don't need to eat on a rigid schedule or eat very specific amounts of carbs at each meal. These types of modern insulin plans really allow children to vary their diet, and they're not as strict as older insulin plans that you may have seen in the past that required eating very specific amounts of carbs at very specific times. And really that was done to match those carbs to the peaking action of insulins. This picture shows a graphic of how multiple daily injection plans work. You can see the basal insulin, that gray line, is given one time daily and then slowly and steadily absorbs all day. And then each bolus dose, or those blue peaks, are given, and they work for several hours to help bring the blood sugar back to normal after eating. This graphic shows the basics of how a pump works. You can see the basal insulin, or the background insulin, just dripping in slowly. And then when it comes time for a meal, the pump user would command the pump to give a lot of insulin all at one time or to give a bolus dose. And just to be clear here, this blue peak here is showing that rapid bolus, not necessarily the length of action of that rapid acting insulin that's going in. Most of our children who take multiple daily injections or use a multiple daily injection plan to deliver their insulin use insulin glargine as their long-acting insulin. This is most commonly known as Lantus or Basaglar. This insulin mimics the background insulin secretion from the pancreas that happens all day long, even when we're not eating. So this basal insulin is typically injected under the skin one time daily. Some kids will take it twice a day, but most commonly it's given once a day. And this is often at bedtime because it really needs to be given at a consistent time. And often bedtime is a time when children and parents are together and can help make sure that that dose happens. It's then slowly absorbed over the next 24 hours, or about 24 hours, depending on the person. Because of the long half-life of this insulin, it takes about 2 to 3 days to reach a steady state. So if we change a dose, often it takes us a few days to see the impact of that dose change. We typically advise families to give this injection at the same time each day, with about an hour of leeway either way. An hour before or an hour after is okay, but generally we want it done about the same time each day. And this dose typically stays the same day to day and is changed less frequently than those doses that are flexed with carbs. So this dose may be changed on occasion by the family or on guidance from the medical team, and we would usually adjust it by about 10 to 20% at a time, and generally not making adjustments on this more often than every few days. This is a picture of the action profile of insulin glargine. It starts working about 1 to 2 hours after it's injected, and we typically describe it as peakless, and that's because you see this sort of steady absorption over time, meaning that it's steadily absorbed over about 24 hours. Bolus insulin, or rapid-acting insulin, refers to the insulin given to cover carbs in meals or snacks and/or to treat a high blood sugar. This insulin starts working more quickly, and it completes its action more quickly than regular insulin, which is an older type of insulin you may be familiar with. And the reason this is a benefit to our kids is that it means that kids who use a rapid-acting insulin have a lower chance of having low blood sugars after meals or overnight as compared to those using that regular insulin that takes longer to start working and then lasts longer in the body. Kids and families determine the dose for this insulin by measuring blood sugar or using their CGM prior to meals, and then they count the carbs that they'll eat and calculate the dose of this insulin using their insulin to carb ratio. So this dose may be different with each meal. The most common brand names for this type of insulin, this bolus insulin, are Novolog and Humalog. You may also hear Apidra, or there's several other insulin names, but Novolog and Humalog are the ones we see most commonly in this area. So again, this is showing the rapid-acting insulin profile. You can see that rapid-acting insulin, depicted by the blue line, typically starts working about 10 to 15 minutes after it's injected under the skin. Then it peaks in about 90 minutes after the injection and lasts for about 4 to 6 hours. The profile of regular insulin is shown in gray here, and you can see how much longer it takes to start working and then how much longer it continues to work after the rapid-acting insulin would be done. And again, that the fact that rapid-acting insulin has a faster onset and a shorter duration of action helps lower that risk for low blood sugars. It is important to understand how rapid-acting insulin works and how it relates to meal timing. So if a child starts eating immediately after the insulin is injected under the skin, that insulin isn't necessarily working yet, right? We just said it takes about 10 to 15 minutes for the insulin to start working. So that means that it's likely that the blood sugar will spike before that insulin starts to work. And in most cases, that's expected. Some families try to mitigate this mealtime rise or spike in blood sugar by pre-bolusing. These are usually families who have a CGM and can start to see that rise. Pre-bolusing means giving insulin 10 minutes or more ahead of a meal, and this is done to help match the action of the insulin to the rise in blood sugar associated with eating. Giving insulin 10 to 15 minutes ahead of a meal isn't usually feasible or safe in a lot of school settings or for young children who have difficulty determining what they'll eat or waiting to eat after that bolus is given. And I just bring this up because I think it's a good reminder that though our insulins are very good at this point, they don't work like physiologic insulin, and there are some limitations to giving them and some things that are not perfect in matching the insulin to the carbs. As you've noticed throughout this session, when I'm describing the insulin profiles, I keep saying things like usually and in most people. And this is because insulin action times are really variable. They vary from person to person, and then even in the same person, the way that insulin works and absorbs will vary from day to day. Some things that can affect insulin absorption are shown here with a green or red arrow. Green means it would speed up the action of insulin, and red means it could slow it down. And if both arrows are present, it means it could affect insulin in either direction. The place where insulin is injected can change how quickly it absorbs. This has to do with circulation to the tissue and other factors. Getting into a hot bathtub, a shower, a sauna, or going out on a hot day can speed up the absorption of insulin, and some people will see a low blood sugar related to that. Exercise can also speed the absorption of insulin. Being dehydrated can slow down insulin absorption, and I wouldn't really say that being well hydrated speeds insulin absorption, but certainly proper hydration does help insulin absorb as we would expect it to. It's also important to note that there are some newer insulins. So for basal insulins, there's now ultra long-acting options. These offer longer durations of action that can reduce variation in blood sugars and offer more flexibility in the timing of doses. There are also ultra rapid-acting insulins that start working more quickly than our current rapid-acting insulins. These newer options aren't routinely used in our practice and are not covered by many insurances in pediatric patients. The information from this program was based on these references, and they'll be linked in the slides below. And then some resources that I really find helpful are this handout from Diatribe, and it describes the 42 factors that affect blood sugars, which is always a good reminder to me that there are so many things at play when it comes to managing diabetes. And then this article from the ADA with very basic information about insulin action times. Thanks for joining me today. Please check back with the DiSH website this summer for additional DiSH a la carte sessions, and also stay tuned and stay in touch for our fall 2021 programming. Thanks.